And to have a successful long-term outcome, there's an interplay of factors. Three key elements are the contact lens, the medications, and the clinical review by the surgeon. So post-operative medications, we generally divide them into three phases. The early phase, which is the first month after surgery, then the transition to a maintenance phase, and then long-term means that they have to be on medicines for the rest of their lives. As far as the medications are concerned, they're basically antibiotics, steroids, and preservative-free lubricants. If the patient has glaucoma, that has to be addressed. And systemic medications are sometimes required, particularly if the patient had a history of hepatic eye disease, and they will be on long-term antivirals. Talking about the antibiotics, for the first month, about 4 to 6 times a day, and then by the end of 3 months, you can taper them down to once or twice a day. Steroids initially 4 to 6 hourly is a ballpark figure. Sometimes surgeons would like to use maybe 2 hourly in the first 2-3 days, depending upon the inflammation. But generally 4 to 6 hourly is adequate. And then at the end of 3 months, the patient would come down to once or twice a day. And lubricants more frequently in the initial phase, 1 to 2 hourly, and then eventually the patient would require them about 4 to 6 times a day for the rest of their lives. Choice of antibiotics. Several antibiotics have been used, and it will depend to some extent upon the local common commensals and the common profile that you get for resistance. But overall, the publications and experience over the last several years have indicated that you need to use vancomycin, 5% QID for the first month, along with a fluoroquinolone, moxifloxacin preferred because it is preservative-free. So after the first month, the patient would then continue on the moxifloxacin till 3 months, and then you can cycle your antibiotics, taking a combination of broad-spectrum antibiotics with less resistance. So you need to have 2 antibiotics, and what is recommended is chloramphenicol and polymyxin B, which would be practical from the Indian point of view. Alternative medication is to use trimethoprim drops, which can be prepared by a pharmacy, and also paclitaxel ointment. Additional antimicrobials or antimicrobial agents would include the use of povidone iodine, 5%. So every time the patient comes for follow-up, the povidone iodine drops are, the bandaged contact lens is taken out, povidone iodine drops are instilled and then washed off. This is done at each visit. And in countries with a warm, humid and hot environment where fungal colonization is likely, it has been recommended that some kind of antifungal cover should be given. So 5% natamycin or amphotericin B can be given in a pulse dose of QID for a week at 3 monthly intervals, or if the contact lens has shown evidence of fungal colonization. The follow-up protocol, initially the first week, then 2 weeks, and then after 4 weeks. So the first month will involve 3 visits, and then after that it's practically every month. If that's not easy for the patient, then every 2 months, provided there is a local ophthalmologist who's going to give shared care. The bandaged contact lens has to be changed every 1 to 3 months, and surveillance culture is recommended. One will monitor the vision, the ocular surface, look very carefully for any cluttering or any spots where the epithelium is getting damaged. Look for whether the bandaged contact lens is in or not, because sometimes patients have difficulty retaining the BCL. Look at the sutures and the other things that you normally look for, a graft, any infiltrates. Look at the optic, is there any evidence of a retroprosthetic membrane forming? Look at the anterior chamber, is it formed? The intraocular pressure is estimated by finger touch, and fundus can be evaluated. The ASOCT is a useful tool to see what's happening to the angle, and ultrasound will be required sometimes if you have, say, a peripheral vision or a retroprosthetic membrane or a sudden drop in vision to see the vitreous hemorrhage or endophthalmitis. The take-home message, that is a viral option to salvage vision. Glaucoma is a significant challenge. With a team approach, long-term follow-up is the key. You have to give a guarded long-term vision visual problem.